We'll go ahead and get started then. Welcome to our quality improvement series, Decreasing Blood Usage. Today's November 20th. And today we're going to talk about optimizing blood utilization in cardiac surgery with Dr. Kevin Brady. On the call today from STS, we have Carol Crone, Emily Conrad, Leanne Jones, Manu Yatsi. Let's see, anybody else that I missed? And then we have Melinda Offer. Also on the panel today, Carrie Webb. Carrie is a data manager at Chandler Regional Medical Center in Phoenix. And we have Dr. Kevin Brady, who's the Chief of Cardiac Surgery and Director of Mechanical Circulatory Support at St. Joseph's Hospital and Medical Center in Phoenix. So welcome, everyone. We're going to have a few very quick STS updates, and then we'll jump right in to Dr. Brady's presentation. The first thing I want to announce today is that the updated PROC ID chart has been posted to the STS website, and that includes PROC IDs 9 and 10. That just happened a couple hours ago, so check it out. It's on the website, just in time for getting our reports back in December, which will include the new multi-valve and multi-valve plus CABG. Today's November the 20th, and we're having our ACSD quality improvement webinar on blood usage. Coming up Friday, November 22nd, Harvest 4 closes. This is OR dates through September 30th. Opt-out for Harvest 4 is November 26th. Then on December 4th, we will have our ACSD monthly webinar. December 13th is the last day to claim continuing education credit for AQO. And then on December 18th, we will have our second quality improvement webinar. Amanda Ray from the University of Maryland, St. Joseph Medical Center will be presenting on that call. So with that, I'm going to turn it over to Dr. Brady.
All right. Well, thank you very much for the introduction. I feel privileged to be here. I didn't realize it was such a big meeting, so I love the attendance on it. I was asked to talk a little bit about how we can optimize our utilization of blood. It's one of our most important metrics that we look at, both from the STS database, but also within our hospital system. And I've been a pretty big proponent of being conservative with the use of blood. And everybody on the call probably well knows this has been an ongoing drive for probably the better part of 2 decades. We started kind of coming about this thought process in the early 2000s. The patients who got less blood tended to have better outcomes with surgery. So it wasn't just about the cost of utilizing blood, but it was deemed an adverse event for patients' outcomes. I trained, like a lot of people, in a transplant center, so there was a different mindset in my training about not using blood because it would obviously result in antibody formation and therefore be detrimental to patient receiving heart transplantation. That's where it kind of started. And it was interesting because I think it's an important aspect of where you kind of get your feeling and your comfort levels about what you do. And you realize that there are patients that you can have a relatively low hemoglobin and do fine. And this is before the data sets came out showing that there was no adverse events, even with hemoglobins less than 7. Anything above 6 was shown to be feasible. And that's a huge mindset change where hemoglobins used to be, discernible to be 10 or above to optimize, oxygen delivery to patients. And that's been subsequently debunked. So that's kind of where we kind of came from, and why I've always had an interest in being conservative with blood. I don't know why I always thought I have a heart transplant center to deal with. I haven't, but I do run a VAD program, and that is necessary for our patients. We're referring on them to heart transplant. We can go to the next slide there. I'm talking. If I need to slow down or I speak too fast, or anybody raise a hand, let me know. But so blood utilization is a huge part of the drive for our quality, and without a doubt, like any great thing you do, it has to be a multidisciplinary approach to this. But unlike a lot of things, it needs a sort of a physician champion or a team champion to really kind of go forward about how to change mindsets and cultures in hospitals to really kind of reduce your blood utilization. So I work at Dignity Healthcare and it's part of Common Spirit. So Common Spirit nationally is probably, I think, the third largest hospital system after HCA and the and the Veterans Administration. So, and I bring that up because before we joined in 2020 as being this one big large coast to coast hospital system, we didn't really know where we stood. I mean, nothing was unblinded to us as physicians. And you know, there's the old joke I have: you put a bunch of doctors in a room, they all think they're 90th percentile, right? But they're really 50th percentile. And so what was interesting when Common Spirit came in is they unblinded all the metrics that we go through in this STS database. So I knew what was going on in Chattanooga, I knew what was going on in Spokane, Washington, I knew what was going on in Sacramento, and they knew what was going on in Arizona. And that's everything from mortality to stroke to length of stay to blood utilization, and it's across the whole CV service line. So on that very first meeting we had, one thing really popped out. You know, you get that sudden panic attack as your hospital is about to be shown on a national level, and sure enough, St. Joseph's ranked #1 in blood utilization across the country, across the spectrum of 138 hospitals. And so, you know, that's kind of interesting, right? Because you knew you didn't use blood, but you didn't realize to what extent that meant nationally. So that's kind of where, for our institution, we kind of look at this across the board and what we can do here at this particular hospital that was working well. So I'm a heart surgeon. When I came to Phoenix first 20 years ago, I covered 13 hospitals, which seems kind of shocking, right? So it was a wild west town. You came and did one heart surgery in one hospital, you dropped your patient, you ran to the next hospital, you did another heart surgery, you ran to the next hospital. I do 3 heart surgeries in 3 different hospitals. So I'm telling you that because you learn how to make sure your patients were dry and not bleeding after heart surgery. So you start off training in a heart transplant center, then you come to a town where it's necessary to run between small hospitals, and it's necessary to be hemostatic because you can't drop off an Uzi patient and you're going to be 30 miles down the road at your next surgery. So that's kind of where we came from. Now I just cover the Common Spirit hospitals. So we do heart surgery out of 2 major hospitals. Carrie's with me here with Chandler, which is our busier cardiac surgery program, and it's probably the 3rd busiest heart surgery program in the greater metropolitan Phoenix area. And I'm also here today at St. Joseph's Hospital. So I operate at both. St. Joseph's Hospital is an inner city large hospital. We have, I think, the 3rd largest lung transplant program in the country. We have an LVAD program here, a durable LVAD program since 2017. We also have a pretty extensive congenital heart disease program with the Phoenix Children's Hospital in town. So, you know, we do a lot of kind of inner city work. These are usually high risk, underserved populations. So as you probably know on this call, they tend to come in with a higher degree of comorbidities and whatnot, and higher renal transplant rates and things like that. So we kind of cover the spectrum from kind of a community involvement in town to something of an inner city kind of high acuity academic hospital. And so what we're talking about here today kind of represents that whole spectrum. So it's sort of what we talk about is applicable to about just every, you know, hospital system you could work at, from a small low volume community based program all the way up to kind of a higher volume program, all the way up to kind of a quaternary care hospital. But coming here in around 2007, we kind of made a direct progress with having a sort of a concerted effort to reduce blood utilization at St. Joseph's Hospital. And then as Carrie knows, I came down to start the structural heart program. I'm a big TAVR guy, so I came down to start the TAVR program at Chandler Regional at the end of 2016, and then started doing heart surgery there. And at that time, Chandler was kind of middle of the road for blood utilization. And within 2 years, it ranked with St. Joe's as the lowest of the hospitals in the entire system with blood utilization. So as again, we're unblinded. So we kind of have an idea that with cardiac, let's say isolated coronary bypass surgery, transfusion rates for blood products run around 46%. And we routinely get around 9 to 10%. And maybe on a high year, we're at 12%, and a low year, about 7%. So it's not just a little bit lower than the national average, it's dramatically lower for the hospital system. And it's just done with the things we're going to talk about today. And you're going to be kind of surprised. There's nothing genius. I know a lot of people ask, are you transfusing people before the surgery? You know, we have a renal transplant program here at St. Joe's, and a lot of people have complex calcified multivessel disease. So we do a tremendous amount of renal transplant patients. They routinely have hemoglobins of 8, 9, and 10 prior to surgery. And that's prior to bypass surgery. So, and we're not transfusing them ahead of time. So we're doing some pretty simple things. And because we're somewhat limited in some of the payer mix and some of the population we treat at inner city hospital, we don't have fancy outpatient, clinics that get to sort of optimize these people for surgery. A lot of people are coming in more kind of urgent fashion. And so we have a limited amount of time to prepare these people for surgery. So we'll go through a couple of things we have here. The next slide there. Basically about, I would say almost half of our patients are admitted with a situation where they need to be revascularized with coronary bypass surgery or undergo valve revascularization procedures or aneurysm surgeries in a relatively short period of time. They're being admitted and they have to stay in the hospital and are rarely able to be discharged home. There's definitely a portion of the population, maybe 30–40%, that come to your office that you can sort of optimize a little bit before surgery, but you rarely have a hemoglobin when you see them. So you're kind of finding out about their anemia in the short term. In other words, within 24 to 48 hours prior to surgery. As we know, there was a short brief period where Epogen became the hot topic, maybe Epogen and iron for inpatients to optimize the hemoglobin, but it was not deemed to be a safe and effective procedure. And most pharmacies now will not let you have Epogen in order to bring patients' hemoglobins up to a higher level before surgery. There are higher thrombotic events. It is a very costly drug. And so we don't advocate for managing people preoperatively with a Epogen type substance. We are pretty adamant about holding antiplatelet drugs. I think that if you can optimize somebody for up to 5 days before surgery to get them off Brilinta or Plavix, you have an opportunity to reduce your transfusion rates. It's a dramatic difference to operate on somebody who got Plavix the day before it got loaded versus somebody you can wait 5 days. Even 3 days can make a dramatic improvement. And this takes a bit of time because there's a lot of push to revascularize patients, not to be sitting around the hospital for 5 days. That's costly, but I think this is something I'm pretty adamant about. And it's something where you bring the cardiology team in, you can really kind of have the buy-in from your referring docs. My hardest times were we were going to 13 hospitals in the community, and there were 3 different groups of cardiac surgeons in the same hospital. And, sometimes the cases went to the higher bidder. There was some, I think, not correct ways of dealing with patients when there was a lot of competitive environment around that would sort of make you operate on somebody earlier than should have. And that's the same for renal function as it is for, allowing patients to metabolize these antiplatelet agents to give them some time. I do keep aspirin on board all the way up to the time of surgery, but for the higher agents, Eliquis and the agents such as Brilinta and Plavix, we do try and wait 3 to 5 days prior to the surgery. We tried iron for a while. Oral iron is turned to be actually ineffective. If you kind of look at the data, oral iron can take 4 to 6 weeks to manage patients to show them having a higher hemoglobin if they got a low ferritin level. But when you sort of look at those patients, it's a kind of something used more post-operatively than it would be pre-operatively. But IV iron does have an option if your ferritin levels are below 200. Infusing iron for a couple of days before the surgery is an option for patients if that would be helpful and impactful. What's interesting is that it did raise hemoglobin, but all the trials that I've seen to date, it did not have a significant impact on transfusion. That being said, it's something in your institution that some surgeons like, some don't, but it is relatively inexpensive, and it's something that really has little in the way of side effects. Next slide. So I kind of deemed a little bit. I kind of touched a little bit on the subject of hemostasis. I think when it comes to surgery, it really starts in the operating room on 2 fronts. One is that you cannot afford to be cavalier on how you achieve hemostasis. And I learned that for a different reason. I didn't learn it because I was trying to have the best transfusion rates. I did it because I was having to leave the hospital and work under a different environment than where I work now. But I think that's where everything starts, right? Is that you are careful about how you do your operative technique in the operating room. Check your grafts twice. I do a lot of Jehovah's Witness patients, and you learn with Jehovah's Witness that those patients need to be as dry as they possibly can because their life depends on it. There's also kind of a drive with anesthesia that in the day when I first started, and this may actually happen in some of your institutions, where anesthesia will unilaterally decide to give blood. I've had that happen even with perfusionists in the past, where a low hematocrit and they prime the pump with blood. And that cannot happen. That has to be a conversation with anesthesia. I'm very lucky. I've got very competent, I would say a very good group of anesthesiologists to work with a good understanding about what our policy is on transfusions, and no transfusions are given in the operating room without the explicit consent from the surgeon doing the operation. And that's, for some places you may be thinking, well, that's the same here, but actually that's not common in the community. I mean, there were kind of anesthesiologists who sort of drove the use of blood, and they were giving blood without even asking it. And so we really changed that, and we're lucky enough to work with one group. It's a group of about 9 physicians who do anesthesia for us, but every one of them understand in the operating room that everything needs to kind of go through, and that includes at the end of the case where things may seem a little oozy and it's giving blood products. It's all run through sort of a team approach. We do use Amicar and THX routinely. Amicar is a relatively ubiquitous drug that helps with antifibrinolytics. It reduces bleeding, and all studies we have here show that both these drugs will reduce the need for transfusion and bleeding afterwards. Aprotin was the third drug that is, may be aware, that sort of was dropped by the FDA, I think around 2007, after an anesthesia study came out showing it increases mortality and renal failure. And it was, I think, kind of a poor study because actually it was given to the highest risk patients, and it did reduce blood utilization by a third. And I think it was more the fact you were giving it to sicker patients. Those patients were higher risk patients for mortality and renal failure anyway. Interesting enough, I think in 2012, they brought that back to Canada and Europe, but in the United States, aprotin is still not available. But that would be the third agent, and if it ever came back, I would feel very comfortable using it. Desmopressin, or DDAVP, is really good for platelet function. It is an inexpensive, easily administered drug that can be given in the operating room to achieve hemostasis. And that being said, it can't be used across the board. It's specifically for patients who have platelet dysfunction. So a classic example are renal failure patients. Patients on dialysis are known to have a decrease in their platelet function, and DDAVP I use pretty routinely for patients like that, or even patients maybe I'm operating Plavix that I've not had the opportunity to hold for 5 days because of ongoing ischemia or urgent or emergent status. But DDAVP can be used in the right subset. It's for von Willebrand, so it's for patients who have deficit in von Willebrand factors, who it was originally produced for. I don't know if your institutions, if you use tags or any other viscoelastic testing. Tags are used by our transplant team. We went through some years back about routinely using in the operating room. So in common spirit, when we go and look at this drive for blood utilization within our system, a lot of programs do use a tag to figure out in the operating room who has a deficit in platelets versus, fibrinogen versus, plasma. But it kind of helps direct what you're giving rather than should you give it. So I don't use that routinely. It's expensive. It's not always available at our hospitals, but it is brought up by a lot of institutions. And if you use it for, say, in a transplant program, it's available to you. It does not hurt to have that information. But again, that's not going to stop a transfusion. That's going to help sort of direct what it is you give. So I think the benefit there is knowing, instead of just giving 2 units of platelets, 4 units of FMP at the end of a complex case, maybe it's just the 1 unit of platelets that you need to give, and you have something in real time and point of care testing that you can figure out how to direct that. Retrograde autologous priming, or otherwise known as RAP, is a very commonly used technique by our perfusionist teams to use the venous blood and the cannula to prime the cardiopulmonary circuit. So very useful in people with low body surface areas where they're small, where dilutional anemia is going to be more of an issue. And there's a lot of techniques used in the pediatric population, like MUF, that it sort of works the same way. But I do believe that both RAP and ultrafiltration for people on the call is like a dialysis machine. It's an ultrafiltration that the pump can be used to pull free fluid out of the plasma. And in a routine case, especially patients with heart failure, say for valvular disease like mitral valve stenosis or regurgitation, you can routinely remove 2 or 3 liters of fluid, and that hemoconcentrates the blood. So if the prime of a regular cardiopulmonary bypass circuit is 1.6 liters, and then you give a liter of cardioplegia on top of that, you've diluted the patient down by almost 2.5 liters of fluid. Well, if your body surface area is 1.7, your circulating volume of blood in your body is 5 liters and I just gave you, 2.5 liters, imagine what that does to your hematocrit. So by ultrafiltrating off fluid, it's an opportunity there to come out of the operating room with a more concentrated hematocrit. The downside of that, of course, is nurses who know me, sometimes you have to give a lot more fluid post-operatively. They come out with a CBP of 4, and then you end up giving them 2 liters back in crystalloid or albumin or whatever you use in your institution. So the last one I want to bring up here is off-pump surgery. So I don't know who out there knows about off-pump surgery, but um, off-pump CABG was a real deal 2001, 2003, the next thing like sliced bread that was going to change coronary bypass grafting, not using a heart-lung machine, not stopping the heart. And everybody learned how to do it. It was the new thing, but it was extremely hard to do. Imagine what that was for both the surgeon and the anesthesiologist to do bypass surgery with the heart moving. Use a stabilization device to hold it still. You use a suction device to move the heart around. So imagine instead of having a completely decompressed heart that's not moving, you've got now a moving target. You've got a heart that you got to move around, which has certain hemodynamic effects to it. And then you've also got to cinch off the blood vessel you're working on. So let's just say it's the LAD. It's perfusing 40% of the left ventricle. You cinch that off, your STs start going up like you're having a myocardial infarction, and you got to sew as fast as you can on a moving target with blood in your field. So you can imagine it didn't go down well. A lot of surgeons had bad results because they were stressed. The anesthesiologist was stressed. It was like running a code in the operating room sometimes. And it didn't really kind of go through the penetrance in the community wasn't high. Its peak was probably 2006. And I think at that time, maybe 40% of programs were doing off-pump surgery. Now, I don't have the recent STS database, but I'm pretty sure off-pump surgery now has probably fallen to less than 15% of CABGs, maybe less. But guess who does it? Me. So and 99% of people who I do bypass surgery on, redos, EFs at 10%, MIs, I do off pump. So, I do about 350 open hearts a year, of which maybe, I don't know, 150 are CABGs. I would say 148 of those, 147 of those are off pump. So why am I bringing that up? Because the Ruby trial in 2007, done through the VA Medical Center, debunked off-pump surgery as being not as good as on-pump surgery. And so it just gave a bunch of surgeons an excuse not to do it anymore because it was hard, it was stressful, and I think everybody, had a sigh of relief. But those of us who did a lot of it didn't really feel that was a good study. And it has actually sort of not been found to be a good study. It was done with fellows and residents being the primary surgeon. It was done at the VA Medical Center. They should have got guys like me who are off-pump surgeons and made us do on-pump, not take on-pump surgeon and make them do off-pump. I mean, I think it's just the way it was set up. But it was the problem with off-pump is they weren't revascularizing as many targets and they weren't sewing the grafts as well, so the grafts were going down. And it just sort of fell out of favor. But there's a group of us that do it. And one of the benefits of the off-pump surgery is blood loss. So imagine that all your blood's not going through a machine. And all that machine does to your blood, it hurts platelets, it dilutes blood, it has inflammatory reactions, and all that is mitigated by doing off pump. So I think on the SDA database, I think the average off pump, off pump coronary bypass time is about a 5.5 hour operation. For off pump, it's about a 2.5 to 3 hour operation. So we routinely do these surgeries in under 3 hours, and that's start to finish. So what I'm getting at is you have a shorter operation, less inflammatory response, but the one thing that really came out of it was blood utilization. So, I'm bringing it up because I do want to be realistic that it's not popular, especially people that are coming out of training. It's hard to learn. And we're so concerned now about our quality metrics. Nobody wants to take on something that has a learning curve associated with it. It's like doing minimally invasive valves. But I really do think it's impactful. And when you look at these numbers of how we achieve such a low transfusion rate, part of it is lacking the dilutional effect of being on pump and lacking some of the inflammatory factors that cause bleeding after being on a pump run. And this is a guy who goes on pump, right? So I mean, I do my valves on pump, I do my LVADs on pump, I do my Bentols on pump, I do a ton of aortic dissections that have to be done on pump. But I love off pump so much that if I'm doing a quadruple bypass in the aortic valve, I'll literally do the 4 grafts off pump, and then I'll go on pump to do the valve. And that's how we have very, very low pump times and cross clamp times when it comes to doing it, because again, less time on the pump is better. So anyway, I'm just bringing that in at the end. I put it at the end because the penetrance of off-pump CABG in the community is low. And if you talk to people who do on pump, they'll bring up this Ruby trial from back in the day, and but there's tons of short-term studies that show off-pump surgery is very effective and it's very good, and in the right hands, it's the right way to do it. But it's particularly important when we talk about blood utilization. Okay, next slide. My slides are going to get easier here. That's the next one. It's yeah, there you go. I made one slide out of this because this honestly is the key point that I'd like to make, and how we're able to achieve a lower blood utilization than most institutions. And it's accepting that it's okay to have a low hemoglobin. And this is a comfort level, and I think this is a cultural change. And this is I can tell you right now that there will be people on here, and there'll be a lot of people who can say differently, but I routinely let my patients' hemoglobin after surgery go into the 6 range. As a matter of fact, I can tell you their nurses at the Dignity Healthcare System will call me every 4:30 in the morning. Hemoglobin's 5.7, hemoglobin's 5.9. And I'm like, wait it out. This is a dialysis patient who came into the hospital with a hemoglobin of 8.8. He doesn't live with a hemoglobin of 15. He can tolerate a hemoglobin of 5.9. Now, why would I do that? Do I want to torture my patients? Am I putting my patients at risk? Are we causing an increased risk of stroke or mortality or anything else? And the answer is no. We don't let unstable bleeding patients or symptomatic patients hover at a low hemoglobin. What you'll find is that a lot of the low hemoglobin in the first 24 to 48 hours is a dilutional effect. If you're taking care of these patients at the bedside, they come out, their first hemoglobin after they go into the operating with a hemoglobin of 14, they hit the ICU, and the first hemoglobin you get is 10 or 11, and then you give them 2.5 liters of resuscitative fluid, and the next morning the hemoglobin is 7.2, and that drops to a level that triggers a transfusion rate. Well, I would beg you to wait, because a lot of what's going on there is the fact that you've hemodiluted the blood sample, right? You've given this patient, especially low body surface areas. This is really particular in females, or anybody who's got a smaller body surface area, because their circulating blood volume is lower. And when you dilute them out, a lot of that fluid props them up to maintain the inflammatory reaction to surgery. And then over the ensuing several days, what do we give them? We give them Lasix, right? Who doesn't have heart surgery that doesn't leave the hospital without getting a dose of Lasix? They almost always do. The tide goes out for the first 24, 48, maybe 72 hours, where the extracellular fluid increases from capillary leak from the inflammation going through surgery. And on the 3rd day, that fluid starts getting reaccumulated in the blood system, and you're given Lasix to go to pulmonary edema. But during that trend, the hemoglobin will follow the same trend as the volume. The more volume in the intravascular space, the more the hemoglobin is diluted, right? So your hematocrit is lower. And then as you start diuresing the patient, what magically happens? They're not producing red blood cells that quickly, right? What's magically happening is you're hemoconcentrating their blood. You're doing what we do on the pump at the ultrafiltration circuit. We're allowing that fluid that dilutional effect to resolve. And when patients are ready to go home in 5 days, their hemoglobin's above 8. Did I give them any blood? No. Did I give them iron? No. Did I give them APO? No. All I did is held the line, right? Hold the line on the lower hemoglobin, accept a lower hemoglobin. Now, I get some kickback. A patient was up, they were a little wobbly in the legs, a little woozy, and it's very easy to pull the trigger, give them some blood. His hemoglobin's 6.9, and he didn't do so well with PT. And I would beg you, the more you become comfortable with this, the more you realize that rarely it's the hemoglobin causing those effects. It's fluid shifts in the body, it's going through surgery, it's narcotics. And those are the things that usually we're sort of dealing with. And that takes a lot. That takes, it takes a cultural shift, right? Your nurses have to treat you, your other healthcare providers, the APPs, the intensivists, the hospitals, they've all got to buy into this, right? Because, you've got to sort of do your thing. So I would say, keep the line, figure out what you're willing to be comfortable with. Pick a number you're okay with, right? It doesn't have to be 6, right? Mine's 6, 5.9, 6, I'm fine in an asymptomatic patient. Maybe your comfort level 7, right? So, maybe your comfort level is 6.5. But once you sort of push that, scientific evidence shows that even a hemoglobin above 6 has no deleterious effects on patients from a physiological standpoint. So that's not true that a hemoglobin of 7.1 in a post-op patient is adversarial, right? It's not. So think about how many dialysis patients walk out there with cardiovascular disease they don't even know about, and their hemoglobins are 8 on a regular daily basis going through hemodialysis. And I think in a situation like a hospital where you can watch these patients, and you're monitoring with an A line or CVP monitor, the dilutional effect is a big part. And so permissive anemia is something I think needs to be used more. Okay. All right. So that goes on to this one. The other thing that I instituted, that doesn't matter if there's a drive-by transfusion, right? So I get called by the nurse, your hemoglobin in your patient's 5.9. We're okay with that. Hold the line. We'll get them up, walk. I round on the patient. I go to the operating room. I do my 2 or 3 heart surgeries. I come back out. And while I was in the operating room, somebody else gave me a unit of blood, right? And this happens more than you can imagine. The intensivist team, perhaps, don't believe what you believe, and they feel the patient would do better with the unit of blood. The hospital orders a unit of blood. The resident on the medical service came by and ordered a unit of blood. Your patient's 4 days post-op, and the hospitalist on the floor orders a unit of blood right before they go home. All these have happened. And so we have a cultural shift here that really you have to have a person who is willing to be attentive and willing to own this. And so what we instituted in Chandler Regional Medical Center after I started working there in 2017, it's the same thing we had here at St. Joe's, is that the only person allowed to order transfusion. I'm not talking about somebody bleeding out, right? We're not talking about somebody who just dumped a liter of blood out their chest tubes and they're on 50 a liter fed. What I'm talking about is all stable patients that are in the hospital on their index admission. Any transfusion has to be run by the cardiac surgery team. In other words, I have to okay it. So that started in the operating room, that the anesthesiologist and the perfusionists understood nothing is given in the operating room. And in the post-operative period, it required the nurses that they take an order from a physician, they had to then call me and make sure that I was okay with giving that unit of blood. And if I wasn't, that required me calling that healthcare provider to say, this is what's going on. This is why I think we don't need to give blood. Because I rely on a private practice model with multiple, cardiology referral docs, I got to keep them happy, right? I can't just be going, you don't know what you're talking about. We all got to be part of a multidisciplinary team. But it begs the time that we can get in there and explain our reasoning. And once you start doing that, once people get to know you, they understand it. And so the calls I get now from other healthcare providers about giving blood is almost gone to none. I still get the 4 a.m. calls because the blood's sent off at 1 a.m. I get woken up at 4 a.m. Your hemoglobin's 5.9, hold the line. That I got to own. But by and large, as everybody understands it, and the reason it's become comfortable to do that in this institution is that everybody's seen how the patients do, right? We have a low length of stay. Our average length of stay is usually 5 days, maybe 6 days. Our transfusion rates are, 10%. These patients do well. They understand that blood is not the answer. It's not going to correct all the things going on with the patient. So again, I want to make sure we do understand this is not emergent, ongoing bleeding. This is not shock. This is not, severely symptomatic patient is so dizzy they can't even get up and walk. Those patients will get blood. What I'm talking about is the routine post-op. And the more you're able to push that limit and the more people believe in you, the more this will work on its own. The less attentive you have to be from the providers that own this. But I do think it starts with cardiac surgery. I will tell you that this has become such a thing. I was bringing up a caveat of my wife not getting a transfusion after our child was born because I'm just known around town for not giving blood. This has worked at all the institutions. When I was at one of the other healthcare systems here, which is Banner. Banner's got the largest amount of hospital beds here in Phoenix and everything. And we had a little small kind of community-based hospital on the edge of town, and we had the lowest transfusion rates across the entire Banner system. And they're about 4 states. And so they were like, what are you doing out of Australia that you're not giving blood? It's the same thing I'm talking about here. It works wherever you go. This is not an institutional mandate here at my particular hospital. It's something you can take and you can roll it out as long as the team, the providers that are involved in the patient care believe that this is a safe and effective way to do things. And so it's interesting now, and you probably in the SDS may not be dealing with this, but when you look at the TCT register, when you look at the structural heart program, which I do a ton of structural heart, they're now under the same mandates, which is to reduce transfusion with TAVRs and MitraClips. And there's now my cardiology brethren are taking what we're doing here and they're running with this in their own programs. And they'll always kind of quote us. I like what our heart surgery guys are doing. They don't give blood, right? But guess what? You've got to own it. You've got to be the person that's going to take those calls when they order it. And you can't just let somebody else do the orders for you. So it's not just rolling this out to multiple hospitals for heart surgery. We're rolling this out to multiple programs within the CV service line, primarily hospital. Okay, we'll go to the next slide there. So just kind of a summary here, surgeon attention to hemostasis, it all starts in the operating room. This is no good if you're not willing to take the extra time to make sure everything, check it twice, make sure nothing's bleeding. Reduce hemodilution in the operating room. Small person, dialysis patient coming in, use pressors. You need to provide blood flow to brain and organ perfusion, but you don't need to worry about renal issues. So if you got a low hemoglobin on a dialysis patient, don't give them 2 liters of fluid in the operating room. If you're an on-pump surgery, use hemodilution and wrap to reduce how much you hemodilute the patient in the operating room with the cardiopulmonary bypass machine. Anemia management without transfusion, right? So in other words, you can get patients by, you can take good care of patients and not have adverse events just because you have a hemoglobin of 7 or 6.8 for several days. Cardiac surgery team, I truly believe in this. Myself and my nurse practitioner, everything runs by, and it's become a mandate in our hospital. And we're not the only system that does this. It has become pretty commonplace throughout the metropolitan Phoenix area that the surgery team are in control of transfusion. Now we have surgery. My ex-partner in another system, my cover month flow, I walk in on a Saturday morning, half his patients are getting a unit of blood. I mean, he wants the hemoglobin at 10. That's his thing. And he believes that's the right thing for the patient. I'm not here to change his mind, but when he rounds up my patients, he knows not to get blood. So, I'm not saying everybody's going to buy into this, but I do think cardiac surgery teams sort of controls it. Ongoing data review and education. So this is a big part of it. This is about sitting in a room with multiple people involved in the care of your patient and showing them these transfusion rates, showing them that this is important to us. I reach out routinely to the hospital service and our med teach service at the hospital to really kind of get them on board about what it is we're trying to do. Same thing for our nurses. We got nursing boot camp. Sit there and go, what's the principle behind you doing minimally invasive mitral valve surgery? What's the purpose of you doing off-pump CABGs? What's the purpose of you not giving blood? I mean, it's really about getting the buy-in and having people understand why this is such a big deal. And that goes anywhere from my bedside nurses in the ICU and floor, all the way up to my referring cardiologists that are across town, to our intensivists, to our hospital service, to the residents that are on those services. And then provider and institutional review. I mean, this is the best thing I think about working in Common Spirit, that we sit there coast to coast and every single program is unblinded on what you do. And like I said, that can be from mortality to stroke. But for blood utilization, we show what every institution gives blood. And so you know where you stand. So if you're on that right side of the curve and 60% of your patients are getting transfused with surgery, and then you're looking at our 2 institutions and it's single digit, like I don't have better patients, right? I don't have patients who aren't sick. I don't have patients who aren't coming in on dialysis with hemoglobin at 9. I don't get blood before surgery. I mean, it is this idea that you sort of roll this out and you can move that metric. And so we've done it now with 2 institutions. And I think this is something we try and roll out beyond just Jehovah's Witness, patient population that can't receive blood. This is really, or patients that are, maybe going to be deemed a transplant candidate in the future. I think it's really a cultural change. All right, next one there. Anyway, I just had a little thing. The ability to reduce blood product transfusions is really methodical, but it's based on evidence-based practice, right? These are studies showing us there's no adverse effect to having a hemoglobin 6.8 in a routine diluted post-op patient. And it really does require the collaboration of healthcare providers. I'm always about the village. If one thing a bad program teaches, it's all about the village. Everybody has to sort of buy into this. And it's really not being dogmatic about things to a certain degree. It's really kind of explaining to all the people around you why this is important and why we all work together. So instead of being told what to do, they want to be part of the success, right? We have something here called a center of excellence with Common Spirit. It's very hard to get a center of excellence for isolated CABG or isolated mitral valve or isolated TAVR. But we all work on that. And once you kind of get people behind it, everybody wants to work for those same goals: to reduce mortality, reduce stroke, reduce length of time in the hospital, reduce transfusions. We're all part of that, center of excellence. And it's not something you can buy. Like, it's very hard to get. But once you involve all the people on your team, you kind of get a pretty good buy-in, right? Because people always want to be part of a winning team. I mean, we got the center of excellence for mitral valve repair last year here, and it went out to everybody. Everybody felt like it was worth the work, right? Worth the work to kind of do the right job. And really kind of do it. And we're very, very proud of that. So I'm lucky to work with amazing people. There's nothing genius about what I do. I'm never the smartest guy in the room, right? But I am the guy who feels that, you know, we can accomplish great things with the right people to go together. So it's not very many slides. I don't give you all those scientific studies to show this, you know, where is safety and globe and everything like that. But we all know that we've had decades now of data showing that multiple transfusions lead to adverse outcomes, right? That it's dangerous and exposing patients and the cost effective with it and the resources that are limited. That just giving blood as a volume expander is the wrong thing to do. And so I'd love to change the culture. That's, if I could say there was one thing about this, taking this on a national level, it's pretty. That's it.
That's it. I thought you didn't have a lot prepared, Dr. Brady.
I'm a talker. I didn't have very many slides, but I can yap way beyond them. I didn't know what my time limit was, but anyway.
Well, I'll let Nancy take. I just before Nancy steps in, I just want to say from STS, thank you so much for presenting to our data managers and to our community that cares for our patients on the quality side. Phenomenal presentation. I do have questions, but I'm going to let Nancy go through the Q&A first, and maybe some of my questions will get answered there. So Nancy, I'll hand it over to you.
All righty. All right. Thank you, Dr. Brady. That was fantastic. And I know all of our data managers are showing you the love with the emojis on the screen.
Was that what that was? I was trying to think what was floating there. I was like, okay.
Yeah, yeah.
Good.
I think everyone loved hearing what you had to say. It was a phenomenal presentation, and we are so grateful that you were able to be here today.
Thank you. Thank you.
All right, we are going to move forward with the Q&A. Let me get organized here for 1 second. Carol, can you
Yep, I
you
got
go
it.
ahead and start, and then I will pick up.
Sure. And I can go on camera. So Dr. Brady, you're not floating alone out there by yourself. Okay. So, and Carrie, feel free to come on. Nancy, if you'd like to come on camera. So the first question is from Judy. She's asking, do you routinely draw a P2Y12 level for your antiplatelet agent preoperatively?
Not routinely. I think if if you're kind of stuck in a rock and a hard place and you feel that you need some justification or you want to be sort of directed about what you're getting into ahead of time, it's okay. But again, I work at programs that we honestly are strapped for costs, right? That's why we're not doing tags. That's why we're not doing, clinics ahead of time to pre-op patients. And so we really try and minimize testing that we're not going to use. So we do not use that routinely, but I'm like tags. I'm very much encourage people to use what they have, but we are kind of limited in what we can sort of provide. So I don't do it routinely.
Okay, thank you. Next question is, could we get a copy of your slides? Usually we post slides on the STS website, and then there'll be the recording of this webinar will be posted on our YouTube channel. Are you okay if we
check that for spelling? I don't know if anybody watches The Diplomat, but it's like my new thing. So I was kind of typing my slides, watching Carrie Russell do a thing with The Diplomat. So make sure there's no grammatical errors in there before you send that.
Did you, Dr. Brady, did you finish The Diplomat?
I'm on second season. Oh, I'm addicted to it. I mean, I cannot stop. I mean, I literally just tuned in this week and
it's the best. I watched the second season in 1 weekend.
Yeah, I'm about to do the same thing. But
that's fantastic. Next question is from Julia Alba. She says, one of our surgeons performed all surgeries off pump, Dr. Tomas Salerno. Don't know if you know him, but she's just making that connection.
Yeah.
From Diane Hollenbeck, she's asking, do you worry about patients with a low hemoglobin, not on dialysis, and not getting a transfusion developing postoperative renal failure?
Yeah, it's an excellent question. So if you're going to ask me what the greatest aspect I am, with patients having permissive anemia, it's not a little dizzy going for a walk, right? It's that I'm going to do something that's going to be adverse, right? And so renal function rates are one of our huge metrics that we look at. I mean, beyond the STS and common spirit, it's actually one of our directed core metrics that we're looking for is renal insufficiency. And Carrie can attest to what we're doing. And so I have every person that we've had a renal insufficiency issue with is because we have tied that down so low, and it's never been tied to a low hemoglobin. So 20 years in town with a substantial, volume of heart surgery. I mean, my group does more, but I personally do 350. And I can tell you that the patients we've suffered the renal insufficiency have never been tied to a low hemoglobin. But it is something that keeps me up at night. And it is something when I have a patient who's got chronic kidney disease and, a lower hemoglobin before surgery, and then post-operative hemoglobin 6.8, and the creatinine's going up, and it's a debatable subject, right? I mean, that's what I'm talking about. Your confidence level goes up the more you feel that creatinine is going to have its nadir on the second or third day, which is what a lot of CKD patients, right? You're coming with the inner city hospital, the amount of A1Cs I see over 10 is incredible. And so I do perseverate on the renal insufficiency, and I will give people blood if I think that's the cause of it. But think about why people get renal insufficiency, right? They get it because of hypotension and hypovolemia. And so hypovolemia does not necessarily mean anemia. But I mean, to the case in point, when you're starting doing this stuff, maybe that's the patient that you don't withhold the blood on. But I personally have let people go with lower hemoglobins, and they've been fine, because that's been brought to me by my providers. I've had the kidney docs come on and go, we give me a unit of blood, that renal efficiency is going to turn around. Go, give me one more day. The creatinine's worse tomorrow. They'll give me a unit of blood. And guess what? The next day, they go past their nadir, the creatinine comes up, and the hemoglobin starts coming up. To start diuresing them, and the hemoglobin follows suit.
That's good. That's really good information. Thank you. I was going to say, when you said, made a comment about a patient with a hemoglobin of 5.9, and you told the nurse to get that patient up and walk them, back in the day, we probably would have been talking about you at the nurse's station.
Right. Oh,
sorry.
I cannot imagine the conversations to go on behind my back. I wear cowboy boots so nurses can hear me coming, so they can stop talking about me before I get to the room. But physical therapists did that to me in the day. Nurses did that. I mean, there's a lot of stuff that people, they have their opinion about. But like I said, I've been lucky enough to be in the same hospital for 2 decades, right? I've been lucky enough that my best proponents are my nursing staff, right? If you ask me who got me busy in Phoenix, it was the nursing staff, right? Because I'm attentive, you're there, they trust you, you'll kind of get it. And they walk fine. Guess what? You give them little flu balls, they'll get up and do their stuff. But I dealt with that. This is not, you're seeing the end product, right? You take me back 15 years, it was a lot of talk behind my back, I'm sure.
Well, good job getting through that. Next question. Do these patients have longer length of stays between surgery? And so do they have longer length of post-op days?
No, as a matter of fact, Carrie can do. So our length of stay at Chandler, which is our busier program, is 5 days. And I think that's very good. So post-op isolated CABG is 5 days. Mitral valve repair, it's 5 days. And at Joe's, we bumped up to 6 days, but we've routinely been 5 days. So you guys have the database. I mean, I've got a folder right here. I've been the chief of heart surgery here for so long. I see this every year. So, I mean, we're proud of that. We're actually lower than the STS data.
Yeah,
and
that's great.
You're talking about people, inner city population, no insurance, hemoglobin A1C is 11, right? Smoking 2 packs of cigarettes a day. I'm not working at the Mayo. I mean, everybody's on the call from the Mayo. I respect you totally, but we have a different patient population, right? These are patients who have more comorbidities, and we're still achieving discharge dates in 5 to 6 days. So
great, congratulations. Okay, if you're not able to get the patient off of pressors and they have a low H&H, do you transfuse?
Yeah, we're transfusing. Yeah. This is 100%. I mean, again, we're not going to jeopardize patients. If you're on a little bit of vasopressin and a dialysis patient where you have some vasoplegia, that's a well-known side effect. I'll weather the storm a little bit, but I'm not going to compromise a patient, right? If you're on 10 Alevafed and your hemoglobin 6.9, you're getting a unit of blood, right? So, but you'd be amazed at how few patients that is. It's not. I mean, we don't have a zero transfusion rate, right? So we do transfuse patients, but I think 46%. You're talking almost half the amount of people getting isolated CABGs in the country get a unit of blood or more.
Yeah.
Why is that? Right? That's that. I mean, I'm not talking about not giving blood. I'm talking about finding the sweet spot of patients who will tolerate
it. It has to do with that culture and the coordination of your teams. I think finally, getting on board with why this is a good idea.
It is not dangerous. Yeah. And you're going to ease into that, right? You're not going to start accepting hemoglobin at 5.9 the first 3 months you roll this out, because you've got to get the buy-in from everybody around you. You have to get people's belief in this, right? There's nothing worse. You got a bullseye on your back when you do something different, right? There's always something out there just waiting for you to fail, right? Just waiting for you to do that. And it may be just anecdotal, it may be not scientific that person had an adverse outcome, but they're waiting for it, right? It's a natural human reaction because you make them feel uncomfortable, right? They don't feel comfortable walking to the hemoglobin of 6.2. So you can't be all Lone Ranger on this, right? You got to sort of start off slow, ease everybody into it. And, it's like everything else in this world. Once you kind of ease it into it, you can start moving the metric. That's why it took 2 years at Chandler to get our blood transfusion rates. You think I went down to Chandler where they didn't know who I was and right off the bat started giving over to, oh,
You would be in the CON's office or
right,
CNO's
right.
office just like that.
Or worse, the cardiologist wouldn't send the patients, right?
Right. Yeah, that's right.
You don't want the nurses telling the cardiologist this guy's dangerous. Like, you don't do that, right? You kind of ease it in and you get the confidence, and then all of a sudden you start rolling it out. So that was 2017, right? By 2019 we were where we were, and we've kept that. And I think Chandler surpassed St. Joe's and lower transfusion rates over the last 2 years. So
I think Chandler last year for calendar year was 20% for total, like give or take a percent. And I think St. Joe's was just below that.
yeah.
So
Or for isolated cabbages,
Yeah.
though, I think we're lower for just the isolated cabbages.
that is just isolated cabbages.
Oh, it
I
is?
was just
Okay.
looking at it this morning.
Okay. Well, there you go. See how I am? I thought it
I
was
tried to pull it up quickly, Carrie. I couldn't do it, so I'm glad you had it.
Yeah.
Thank you. Dr. Brady, could you hold on a second. Could you review the problems with giving transfusions to the patients? I know there's many, but could you review just high level why reducing blood utilization is a priority and important?
Yeah. So, first and foremost, we know that when you see these studies and they show, okay, there's an adverse event for people getting transfused. So first of all, people getting transfused have higher mortality rates, higher renal dysfunction rates, higher stroke rates. But it's like the protein thing. It's a cause and effect. Are people who are getting transfusions sicker patients? Are they having more emergent surgery? Are they in a situation where it's not the blood transfusion that's doing it, it's the underlying medical sort of situation? But as you tease that out, when you start teasing out and you taking out the confounding factors, in other words, you sort of compare apples to apples rather than apples to oranges, patients who get more blood do have worse outcomes, even when you're risk adjusted. So that's a huge part of this, right? So when you start taking away the emergency parts of things, willy-nilly giving patients of blood, we know with no transfusions, we have trolley and we have higher renal dysfunction rates when you give patients mass transfusions. But even lower transfusion rates tend to have the same inflammatory effect. If you've ever had a patient have a bad adverse, outcome from a platelet transfusion, you'd know this. So I think, giving people blood is not a safe because it does increase risk of pulmonary renal insufficiency issues. And it is costly. It is a limited resource in hospitals, right? We all know that. I mean, this is not something. I heard some factor like 28% of all blood transfusions in the country had to do with cardiac surgery. I don't know if that's true, but I remember reading a paper on that one time. I'm like almost you think it'd be trauma, right? But it's not. It's cardiac surgery. So that's a limited resource that we use elsewhere, and so it's costly to the hospital to give it. But those are kind of the real driving forces. The days when we were worried about exposures with blood products. I mean, there's people around old enough to remember the days where they get very nervous about being given blood, right? But I think that fact is very, very low. Any bloodborne transmissible agent is almost negligible these days. But again, for patient comfort level, it's still something important. And then antibody, reaction, right? For any patients who may need anything on the road, you don't want to give people blood that don't need it.
On that note, do you have your team? Oh, thank you for that information. That was helpful. Do you have your team call you before transfusing cryo, FFP, or
Yeah, when we're
platelets?
for this conversation, I lump everything into one bucket. This is not just about packed red blood cells. This is about cryo, FFP. So it's anything that requires a transfusion of a blood bank product is run by first, because they also have side effects, right? I mean, there's a directive of our institution to reduce platelet utilization. Platelets are kind of that thing, right? You don't want to transfuse a patient in packed red blood cells, so you give everybody FFP and platelets at the end of the case, right? Now you got an exposure and a cost, right? With the idea that you may or may not reduce bleeding, and you didn't give any packed red blood cells, but you're still getting blood products. So,
yeah.
But the point of this conversation, it's the same. It's just that hemoglobin levels. Like, when was the last time somebody called you because your INR was 1.4 or your platelet count was 80, right? You maybe the whole Plavix or something, but they do call about the hemoglobin. So the hemoglobin's up front and center, but this is across the board on all of the products. And at the end of the day, I just did a young 37-year-old mitral valve repair, and his fibrinogen level was 88 post-op. I'm like, that's no problem. And 10 hours after surgery, he started oozing, right? So I give him 20th cryo when he stopped oozing. So wish I'd given that 10 hours before, not necessarily, right? I mean, it was sort of a patient. He wasn't bleeding. He didn't need it. You have to sort of go by that. But that blood product was run by me. Yeah.
Thank you. I'm going to do 3 more questions for you and Carrie, and then you're welcome to jump off. I know we're at time and you're probably a busy guy, and Carrie's probably a busy woman. And then Nancy and I can stand and finish up these other questions. There's just a few. How far in advance of surgery do you discontinue your heparin drip?
You can run that till I roll in the operating room. Because guess what? I'm going to give them 20,000 units as soon as I, take the mammary down or, cannulate. So, or while I'm cannulating. But as a general rule, I stop heparin about 2 days. I'm sorry, 2 days, 2 hours before the operative time. So if it's a 7 a.m. In the operating room, I stop it at 5 a.m. But honestly, if we're rolling into the pre-op area and the heparin drip is accidentally still going, it's not going to change anything, right? Because the heparin we're going to reverse at the end of the case, and everybody's going to get a large dose of heparin. So endoscopic vein harvest or radial artery harvest from the arm or the leg, when you're on heparin is, can increase oozing, but I haven't found it to be an issue. I wouldn't cancel surgery for that. But I had a strict rule, usually on my pre-op orders, to stop that 2 hours before surgery.
Thank you. Do you routinely use Swan-Ganz to monitor hemodynamics for volume resuscitation?
I do. So this is interesting you brought that up. You know how many we use it on? 100% of our patients. And I saw in the SDA database that only 56% of people around the country use a PA catheter. I was shocked at that. So it's probably a cost issue. And now a paper just came out last month saying that if you had a PA catheter, your patients did better. You had less adverse outcomes after heart surgery with a PA catheter. So isn't that interesting? I was just about to stop using them on low risk, young off pump surgeries. And why am I doing it now? I'm thinking I'm doing the right thing, because one of our big directives is renal insufficiency. And, one thing I hate is putting a PA catheter in and somebody yanks it out at 3 a.m. And then I come in the next day and I'm like, okay, now the creatinine's 1.4, and then I don't have the information I need. So honestly, it's maybe this is old school, but I think the data now is suggesting PA catheters are actually helpful. So I'm probably going to continue to use it. So we use it. I mean, not 100% of my patients, but I would say 90% of my patients get a PA catheter. And the ones who don't are usually like, a very straightforward, Lima Lad, the unicorn kind of procedures where I'm not really too worried about hemodynamics.
Yeah, all of my patients that I've ever taken care of had Swan-Ganz. I don't know as a nurse what I would do without it, because you don't know what's going on, right? How do you tell the surgeon what's going on with the patient?
Right. I think Carrie was in the room when she goes, when I looked up there, I go, only 56% of people in the SDS database have a PA count. I'm like, did I miss something? But anyway, like I said, that study just came out last month. So apparently we're in the right using it. So stick with your PA catheters.
Thank you. Is this okay? Your the blood protocols that you use, the not giving blood, except for hemoglobins that are really low, unless the patient is symptomatic, things like that. Are you doing it for all cardiac surgeries as an aorta procedures?
Everything across the board. It doesn't change, because once you start changing that, that's where you're going to get the fallouts, right? Because you're confusing people. So one thing we did back in the old post-op orders when I first came to town, it would say on there, transfuse for hemoglobin less than something. We got rid of all that. Now it's called the cardiac surgeon for any blood product transfusion. And so what that does is, if you use it across the board, so I'm putting in an LVAD on a guy who's on ECMO or an Impella, right? Like, he's going to get blood, right? I do a lot of aortic dissections. They're going to get more blood than I use in a year, right? So the point is, the best thing to do is just manage everything the same, because the blood utilization for isolated CABG and isolated mitral valve and isolated aorta, it should be the same as doing a CABG AVR. Like, you're still exposing the patient, you're still using a resource, you're still not using science, right? So the best thing in my mind is not have dichotomy within the orders, because you confuse people, right? So like, once you mandate that every blood has to go through the surgeon, it's easier to control it. If it's just the isolated CABGs, people are like, well, can I get my blood last week? And
is a mitral valve in a CAB an isolated CABG, or like, am I calling you for that?
Yeah, we got that for our 6-hour extubation orders. Isolated CABGs, isolated, mitral valve, and MBRs all have to be extubated within 6 hours. And then I come up with a CABG mitral valve, and they're scrambling, and I'm like, no need. There's no 6-hour window, right? Like, but it's best to have that mentality when it comes. It's going to be more compliance with it if you stick with just one game plan and not confuse people.
Yeah, great advice. Okay, and then we have 2 other questions. Or one other question, I guess, not specific here to you're welcome to stay on. I'm just going to wrap it up with this question. And then we'll end it. The question is, I want to express that not having the last harvest report before submitting the next harvest it should not be okay. And it's not, Kim. We don't like doing that. Yes, there are new risk models, but the reason why the report is delayed is because we extended the harvest twice. Once for a really bad hurricane that had hit the southeast, and then for a cyber attack that had wiped out it was a couple of cyber attacks that happened near the same time, and it affected about 40 hospitals. So we were trying to get as much data in for this harvest as possible, so the star ratings have a larger N and a larger number of patients in it. So we do apologize that the report is delayed, but it was a decision that we made based on focused on trying to get the most amount of data in the harvest for the best outcome calculation. So I appreciate the feedback. Mary says, excellent presentation. Thank you. And I guess we're going to wrap it up. So
Fantastic.
thank you, Dr. Brady. Thank you, Carrie. Good to see you here, just as it was to see you in person at AQO. Thanks again. I hope you have a great rest of the day, and thank you for making cardiac surgery safer for patients.
Thank you, everybody. Appreciate you having me.
Thank you so much. And thank you everyone for joining. And just remember, if you have a blood conservation project that's been successful, we invite you to share it with us on an upcoming webinar.
Oh, and happy Thanksgiving. Thanks, Diane. Gobble, gobble, gobble. Happy Thanksgiving. Be safe if you're traveling. Thank you, Carrie.
Thanks, Carrie.
Welcome.